we've had a wonderful 3 days together. We've looked at a lot of different ideas, but what really matters is how we collectively carry it forward. Some of the design of these meetings is straight up networking, of you connecting with other people that you otherwise wouldn't have met and had a chance to talk to over dinner or on a walk in the afternoon or over breakfast, and we hope that you will leverage those relationships. Some of it is individual professional development for each of us, and I know I learned a ton, and in my day job, as I think about how we at ABIM move forward with this, just the educational capacity of the meeting is not to be discounted. But as Daniel just said, we do have a commitment to the extent we can to carry forward some of the work, and that depends entirely on your participation. We do have the mighty staff of 5. We can schedule, we can create agendas, we can create documents, but we can't carry that work forward without each of you and engaging and being part of it. So I hope that you will think about what you'll do on Monday, and that it may include some carrying forward work from this meeting. What Reneé and I wanted to do was reflect a little bit on some of the things we've heard and some of the questions that I've heard from you that you wish Reneé had talked more about, and give her a chance and to respond to that. And as I think about the meeting overall, I have to say I go back to Jackie's opening line, to state a fact is to take a side. And that is just a really uncomfortable and weird world for all of us to be living in, and I think we've all been reflecting on that because we think there are these things called facts that are independent of sides, except it turns out that they're not, much as we wish they were. And my reflections in the opening use that ridiculous term, democratic epistemology. How are we going to decide what's true? There are a bunch of people in this country who are deciding what's true based on what's in the Bible. There are a bunch of people who are deciding what's true based on what a particular political figure says. That is the reality in which we are functioning, and those of us who have a commitment to a certain disciplined way of knowing what's true, which relies on a methodology that we study and we learn and we practice, and we learn. One of the lines in Yule and my article that I was sort of proud of is, we've found as a profession it's a safer way to practice to rely on these methods than individual intuition. But that is not necessarily where we are as a culture right now, and I think wrapping our minds around that is really difficult. I was also really struck by David Scales' animated slide, and I'm going to ask him if I can use it, describing the way that we, in our classic way, generate evidence and public health guidance and put it together to the world of networked public health communications. And that idea that there are all these conversations going on, and I think the fact Chicado slide of what's happening in official media and what's happening in the rest of the world, different conversations, we clearly have to get better at that. And I think that we also heard from the panel this morning that we're doing all this in an environment that feels quite threatening. And it feels threatening. Christina Lawson's story is compelling and terrifying. I think most of you know that we are, there was an article in the local paper by Stanley Goldfarb about our meeting here and mischaracterizing it, and part of the whole broad attack from the Wall Street Journal piece. And a bunch of us are starting to see unpaid unpaid ads on our Twitter feeds that are saying things like, if you know something bad about ABIM or the foundation, report it to us. And it just has a very threatening and ominous kind of quality. So I think we've learned a lot, and now we want to shift some to some going forward strategies. And one of the first question I had for Reneé was, several of you have observed in Renée's comments that with her work on election integrity, there was a door she could knock on to say, hey, we've identified this problem, but in her work on vaccination, immunization, there was not a door she could knock on to report this problem. So I wonder if you could say something, Reneé, about what that election integrity structure looks like and how we might think about emulating that within the healthcare world.
So the way that ISAC's Information Sharing Advisory Centers, is what the acronym stands for, they came about actually as a cybersecurity best practice to create environments where public-private conversations could be had about emerging cybersecurity threats. This was established in 2015 under President Obama as this question of how could entities within an industry, all the companies within an industry, have an understanding of things like ransomware attacks or new and novel methods for trying to infiltrate companies. How could those sort of cybersecurity threats be discussed? And so they were originally pioneered as this way to, I think there are maybe 27 or something of them for sectors that US government has identified as critical infrastructure. And that's where the model of the ISAC came from. But not everything has to be, the point was not necessarily that there needed to be a government public-private partnership entity for this, or that cybersecurity should be the threat. It was that gradually, as, in the context of elections, information threats to elections kind of got rolled up, and there's a lot of debate about to what extent that should have happened, but it did happen. Information threats to elections did get ultimately kind of rolled into this model of the sort of, in the cyber domain, what kinds of threats are taking shape. This was in part, of course, because of state actor interference. There was a pretty clear argument for why that should expand at that time. But the overall model, the point of it is really that in the election integrity work, the state and local election officials, regardless of what party they're in, are participants in this entity so that they can understand if something is happening in Michigan, it might also happen in Arizona. And so it's just a way for them to be appraised and aware of what is going on. And that's really the value. It's just the kind of situational awareness for what is happening in the information environment, in the cybersecurity environment, around their particular professional space. And so what I was getting at with that, though, is that when we saw things that said, that made very clear allegations that some sort of fraud was occurring, or some sort of voting machine had been tampered with, or some sort of, Italian satellite was changing votes. These are the sorts of things that that the state and local election officials want to be aware of so that they can respond to the people in their community with accurate information as quickly as possible. Or if people are saying these things online, so they can actually go and investigate and see to what extent, were Sharpie markers actually a problem? Here is the official statement on the Sharpie markers. So that dynamic is more one of, it creates an environment in which people in a variety of locales who are all operating under the same kind of shared mission have visibility into how particular threats are manifesting in different spaces. So I think the parallel with public health was, as we saw narratives related to vaccines, again, the sort of claims and concerns that people had, rumors about things, there was no place, there was no kind of point of contact, there was no networked dynamic among state and local public health officials, whereby there was a way to say, hey, this narrative really seems to be troubling people. This rumor is really going viral around a nurse who was vaccinated and fainted in this locale, and that claim is now going viral and it is spreading, and you might want to proactively talk to your community about this thing that is happening. So there was no way to create that situational awareness, and there was no way for members of the public health community to kind of engage with and ask questions from people who study social media about what was actually happening on the ground. And so what I was kind of advocating for is that is the sort of thing that I think going forward really needs to exist. I think there are some entities that are trying to do it. Joe Smizer's team at Public Good Projects, PGP, is one where they have a dashboard, but they also try to bring physicians into the conversation. On the harassment front, I am trying to remember the name of the group. They were actually kind of rolled into PGP also. I think it was Shots Heard Around the World. A couple of pediatricians who had been targeted by anti-vaccine activists very, very viciously review bombing, all of, harassment, threats to family, all that stuff, really came together again and said, we are going to create a Facebook group whereby physicians who are under this kind of harassment attack can connect with other people who have been through it about what they should do, and then also who can get support to kind of help them through it. And so these dynamics, the recognition that we don't have to treat each individual incident as a separate, unique, and distinct thing, but instead can think about it as a pattern, that's where I think some of the more tightly connected, the opportunity for that kind of deeper connection exists.
And for what it's worth, shots heard around the world, I stumbled into them somehow, and basically you get to sign up to be part of a response team, and you get vetted. You have to fill out a questionnaire and provide some institutional platform, and then they're inviting you to be part of a response team, which is an existing piece of infrastructure that didn't come up here, I don't think any of us knew about, but is important. One of the things that has been thematic in the ideas that people are working on, you talked about making communication front and center of this. Can you say more about what you think that looks like? What would be our most effective opportunities for making communication front and center?
There's some interesting dynamics in how people communicate online. A lot of the time, it's communication for the bystanders, right? You're putting something out because you are expecting a wide audience to see it. And it's not necessarily as effective as more one-on-one personal communications. So interestingly, even as trust in institutions, which is a very big, broad umbrella term, is declining, trust in physicians actually remains quite high, right? And so there's a little bit of a discrepancy there. And so one of the reasons for that is that people trust their doctor, their physician, their pediatrician, even as what their idea of the institution of the CDC or the institution of the World Health Organization has their kind of trust and respect for those bigger organizations has perhaps taken a hit based on studies that Pew does periodically. So there is this opportunity then to engage very one-on-one in your, in practices and in communities. And we spoke with a couple of doctors who had reached out because they wanted to understand dynamics that they were likely to hear in their, like what is coming up, what is percolating up, what social media memes should I be aware of that my community might be seeing, because they're not going to necessarily proactively raise them. They might not want to look stupid in a conversation with me, but I want to know what is happening so that I understand where things are going. And also they spoke quite a bit about wanting to have those one-on-one conversations. During COVID, there was a place called Clubhouse. I don't know how many of you know about or participated in Clubhouse. I see like a couple of hands. So Clubhouse was like an audio chat, and particularly during the pandemic when everybody was stuck at home, people would like hop into these voice chat rooms and you would listen. It was almost like radio, but you could get brought up to stage and then you could participate. And so there were a lot of COVID-related conversations on this app. And of course, you can't moderate. Nobody is going to go and like play whack-a-mole with what somebody is saying in real time in a voice chat. So what you had instead was this dynamic of counterspeech. You had physicians who would actually go and participate in these rooms. And then a couple of them actually started hosting their own rooms. And there was a really fascinating article that went out about Black physicians in particular who were very concerned with what their community was experiencing and wanted to speak specifically to people who had a particularly longstanding distrust for valid reasons of their experience with medicine. And there were narratives that were coming out about people being experimented on when communities were given access to vaccines early. And so these physicians would actually go on Clubhouse and they would set up these rooms and there would be hundreds of people in the room and they would just bring people up to ask the question and then they would have a conversation about it in public. So in public meaning in this Clubhouse room. But it was a very interesting dynamic of physicians engaging in an environment that was perhaps less adversarial than Twitter, but having that communication where bystanders could hear it as well. So I think there's a few things here. There's this, what you choose to tweet in a very adversarial platform like Twitter, that is one particular type of communication. There's what you say one-on-one to patients and people in the immediate community. There's ways to use these newer channels, these smaller, tighter channels that provide an opportunity to to engage your community without necessarily all of the noise and harassment that a bigger platform like Twitter might bring. And then there's opportunities to create Facebook groups where people can engage in sustained conversation with physicians and can feel like they're in an environment where they can ask a question of a doctor that they have a personal connection to. There are some of these groups that exist on Facebook called, related to childhood immunizations, where doctors and nurses participate in these groups and try to have conversations with people in private spaces on Facebook. So there's a variety of different ways in which you can use the tools of social media. Twitter broadcast is only one, and it is usually the one that attracts the greatest degree of harassment. So for people who are looking for ways to put communication front and center, to recognize that the conversation around these things is so critical to people trusting and feeling confident in the decisions that they're making, you don't necessarily have to do that in the arena of Twitter. There are other ways to do it. So it's participation in different spaces and understanding the ins and outs of each one and what each one can do to advance the message.
Well, certainly, thanks for that, Reneé, and certainly a lot of energy in the room in the last few days has been around, you made the statement, how trusted physicians are. Christina Lawson painted the dark side of that. If they can take down physicians, the most trusted people, there's a lot of other things they're going to be able to do. But the idea of having strategies, and a number of the going forward strategies do this, try to make physicians more effective communicators. Bob Wachter's quote, we should be teaching influencers science, but we should also be teaching scientists to be influencers. Yeah. And so the whole infrastructure, educational infrastructure, and I think we're deep in this room in medical education, both undergraduate medical education, postgraduate medical education, and medical education across the career. And I think the opportunities from several of the going forward poster boards really focused on activating that across the discipline of medicine. So the professional societies have annual meetings. Can there be sessions in those meetings? There already are, but can we up our game on making physicians more effective social media communicators? And so there's a lot of discussion about individual physicians, but there was also a lot of discussion about community response. And I think there were, David talked about, if you're not talking about community, you're not talking about anything. Shoma reminded me to think more about an asset-based approach where we recognize how much capacity is already in the community and figure out how to activate it. Yep. Can you reflect on that? What does it look like to have an asset-based approach for us to be trying to activate resources that may already be there?
Yeah, I think it's huge. I think it's really important. I think it's hard to do sometimes. We try to do this with the kind of federated partner model that I kind of alluded to when I was speaking, by having regular conversations with civil society organizations. There's varying degrees of the strength of those ties. Civil society organizations, they have their own missions, they've got their own budgets, they've got their own constraints. There's not always a direct overlap in what we're trying to do and what they're trying to do. And so we try to create very open channels of communication without an expectation that something is going to, without necessarily you are committing to this and we are committing to that. There are those relationships. There are many, many fewer, and that's because usually that requires somebody dedicated to to relationship management, to keeping those channels of communication open. But what we try to do is understand, movement mapping, I think is a term I learned when I was at Mozilla. I was a fellow there for a while, and it was this question of how do you not reinvent the wheel or step on anyone's toes? And so you actually kind of start your process by figuring out who's doing what capacity they have, and what they're working on. And then from there, the outreach is really like, this is a need that we see that we are trying to fill. We see some adjacencies and complementary areas in the following spaces. We just, we don't consider ourselves competitive in any way. We're not competing for funding. We're not. This is again the difference as academic institutions talking to civil society. There's we just have like different operating models, and we try to say, how can we be helpful? This is what we would like to do, and this is how we think that there's opportunities to advance the shared goal going forward. So first, it's just who is in the space doing, doing what they want. A lot of times that takes the form of looking at who is speaking, who is writing, who is talking. When we did Vaccinate California, there were bunch of different community organizations in public health. Some focused on particular demographic communities, some focused on particular economic situations, some focused very regionally. California's a huge state, very regional focus. We also wanted to understand, again, this question of who is the best counter messenger, who is the best response. It's not always like the mom group. Like, we're useful for some things, but there are times when it should be a physician group who is speaking, or a nurse group who is speaking, or a parents of medically fragile children specifically who are speaking. And so by creating that map and that understanding of who is out there and who's doing what, and saying, like, this is an area where I would like to be involved. Here is, sometimes you have to start your own thing. Other times you can just work through affiliate models of saying, I'd like to participate in what you have going on. So that's we spend a lot of time. I have a student RA who's basically dedicated to, who is doing what and where. Just keep me posted on interesting speakers, new organizations, because we can also signal boost that stuff too. Stanford doesn't have to be the speaker or writer or originator of the idea. Sometimes it's more effective to boost the work that other people are doing, that they've been in the space for a long time. And I think that understanding of ways in which different stakeholder types can collaborate is a key piece in moving forward. And I feel like physicians, you're already very much aware of your local public health officials, local hospital groups, local parent organizations.
Probably some of us more than others.
Yeah.
But yeah. And I certainly was taken with the New York City Department of Health presentation, where renaming the misinformation team to the community concern team was an important frame shift. That this isn't, it's not like you're going out to say you have to stop this. It's really trying to connect. Something on things they care about. So something else I wanted to ask you about is technological architectural changes that are out of reach of this group. Larry Lessig talks about the architecture of technology being a regulation, being a really powerful form of regulation. Your thoughts on, and where a lot of people have talked about the business model of medicine, never mind the business model of Shoshana Zuboff and surveillance capitalism. What are the opportunities for?
Well, there's one that's right now immediately top of mind. I think August 28th is maybe the due date, but somebody can fact check me on that. It's Facebook has this thing called the Facebook Oversight Board, and the Facebook Oversight Board reviews its policies. There's a variety of opinions on the legitimacy of the Oversight Board and its dynamics. Holding all of that aside, Facebook has requested that this independent body evaluate its COVID-specific misinformation policies, asking what should it do going forward, what worked, what didn't work, and a bunch of different questions related to this. In response, what the Oversight Board does is it solicits public comment from expert organizations, almost the equivalent of submitting like an amicus brief. I'm not a lawyer, but this dynamic of if you have an opinion on this, either as an institution, an organization, a physicians group, public health channels, there is an opportunity to say this is what we thought went well or did not go well in our understanding of Facebook's policies and the dynamics that we saw on Facebook during COVID. So that in turn will be read by the body and will be led to inform policy recommendations within Facebook. This is kind of like a self-regulatory model specific to that platform, but it is a way to to have some influence in shaping the direction that policy might go. There's also things like regulators in Congress do regularly reach out to the platforms, and I remember during the measles outbreaks in 2019 asking, to what extent is your recommendation of anti-vaccine groups and pages and your acceptance of anti-vaccine money for ads implicated in this process? Before they wrote those letters, the legislators who did so reached out to a number of different organizations, asking for not only evidence in the form of data, which is the kind of stuff that we work with, but physicians' experiences in engaging with patients and how often they were hearing that these people had this experience on Facebook and then made this decision. So there are ways to again participate in those conversations at both the state and the federal level, I think. And then there's just op-eds, right? This is another area where the platforms are sensitive to to public pressure and to changes in public sentiment. And so even though in the US regulation is often quite stagnant, a whole long list of reasons for that, but there are opportunities to participate in the public conversation about ways in which information on social media is impactful, and to be part of that conversation about what should this look like going forward, whatever your opinion on that may be.
Great. Well, I think the last reflection I want to close on, I mean, I'm a strong believer of you lead from where you stand, and I think we've talked about individual clinicians and where they stand, and we spent some time talking about community civic partnership organizations and where they stand, opportunities they have. We just talked about technological platforms. But one of the major animating ideas for this meeting was the medical community and how it functions as a community. And I just want to share a quote that's very influential to me from The Social Transformation of American Medicine, Paul Starr's book, where he poses the question of, he starts with Benjamin Rush counseling his colleagues in colonial Philadelphia to plant a garden. Why? So that they don't starve and have the improvident wish that a plague will strike the community and then they'll get fees. And he uses that to describe the economically and socially marginal position of physicians relative to everybody else in society in 1790. And of course, he's writing in 1984, 86, where physicians are anything but marginal, and they're very influential, and they're really in the middle. And the question he's asking is, how did that happen? How did physicians derive their authority? And he has a paragraph where he says, physicians derive their authority not from individually received wisdom, but from being recognized members of a community. And I think our ability to constitute ourselves as a community and put individual physicians forward as members of that community or not, and this may seem like a really abstract thing in terms of people having validated expertise, but how did we get to a situation where the most influential physician voice in federal policy was a board-certified neuroradiologist with no training in epidemiology and no training in infectious disease, and yet that's where we wound up. So I think it's on us as a physician community to try to make clear where we think the science is, and I've heard several people talk about it needs to be science-based communication. We need to figure out how to do that in a world where we do have the networked public health communications, and we don't reliably, nobody gets a privileged perch in all this. But I am really grateful to all of you, to you, Reneé, for coming, and to all of you for devoting your time and energy to this really critical topic, which Christina Lawson told us is one of the most important issues facing not just medicine, but the country, and how we can figure out how to create some clarity and public confidence. Clearly it's through collaboration, clearly it's through activating existing networks and partnerships, but it's also teaching ourselves new tricks, and I hope we have a way to do that. So thank you all. It is noon, and again, my gratitude to Daniel and to the team that put this together, and thanks for coming, and thanks for giving us so much to move forward with the 2022 forum. Thank you very much.